So thanks for all coming today. I know some of you have come from up on the Cape. Today I'm talking about Polycystic Ovary Syndrome and what it means for Aboriginal and Torres Strait Islander women. I'm not sure if any of you have heard about it, and it's quite a complicated story, but we'll take it a step at a time today and hopefully understand a bit more about it at the end. So first of all, how do you know if a woman has Polycystic Ovary Syndrome, or PCOS as it's called? Basically you need to have two of the following three things. So the first is periods that don't come around the same time every month. So most women would find that they'll get a period at the beginning of every month or the end. And for some women with Polycystic Ovary Syndrome, they might get them very close together. And some women can actually have periods that come at the same time every month, but for most of them they'll have quite irregular periods, so they might come every 5 weeks, 6 weeks, some women skip months altogether. So that's one sign to look out for. The other is that all women have both male and female hormones, and the male hormones that we're particularly interested in is one called testosterone. And if you have too much of the testosterone, we can either pick that up on a blood test, or it can cause problems with hair on the face or the chin or the chest or the tummy, or sometimes even some balding at the front of the head, like men sometimes get as they're getting older. And the third thing is polycystic ovaries on ultrasound. So I'll just show you some pictures that illustrate some of those things. So this first one is showing what happens with the hormones. So when you're having your periods that come every month and you're having an egg grow and get released every month in case that might enable you to get pregnant, what happens is that there's an interplay where the hormones talk to each other from the brain up here, and that's these ones here, and from the ovaries down here, and these are these ones here. And you can see that they're going up and down, and that's because they're talking to each other and they're helping the egg to grow and to be released here, and they're also changing the lining in the baby bag. So here it gets nice and thick in case you become pregnant, and if you don't, then you'll have a period. So that all gets interrupted in Polycystic Ovary Syndrome, and you don't get that nice cycle of events happening. And these are some pictures of some of that hair growth that I was describing between the below the navel there and along the cheek and chin there. And this is a picture of a normal ovary and what that would look like on an ultrasound, and this is a picture of a polycystic ovary and what that would look like on an ultrasound. And these black circles are basically the little sacs of fluid that the ovary is growing, that the egg's growing, and any fluid on the ultrasound shows up as black, so that's what they are there. It is important to remember though that you can have polycystic ovaries on ultrasound but not have the whole syndrome. So about 20% of women without Polycystic Ovary Syndrome will have polycystic ovaries on ultrasound. So certainly I see women who come in a bit of a panic, having been told that they've got that, but they don't actually have the whole syndrome. So it's really important to be aware of women who might have Polycystic Ovary Syndrome. So there's quite a spectrum. So it ranges from you might have a slim young woman who perhaps has polycystic ovaries on ultrasound and may or may not have irregular periods. And then you might have a woman who is in her mid-20s who has irregular periods and some hair growth and can't get pregnant. And right through to some women who are carrying a lot of extra weight, have diabetes, hair growth, irregular periods. So women can present with any of those things as one of the things that are bothering them, and it's important to remember that they may not have it, but it's worth investigating to find out whether they do. And the other thing to remember is that generally the more weight that you're carrying, the more likely it is that you might have polycystic ovaries, you're more likely to perhaps have Polycystic Ovary Syndrome, and the problems that you're having with it can become worse, such as diabetes. So how common is it? It's probably around 4 to 8 or 5, up to 10% generally, by different criteria. So by an older criteria, it's around 4 to 8%. Certainly with the newer diagnostic tests that I was telling you about earlier, with those 3 things, it's even more common. So around 12 to 18% in an Australian population in South Australia, and in Aboriginal and Torres Strait Islander women, it's been shown to be as high in Darwin as 21%. So it causes major health and economic burden in Australia. So this picture just illustrates what happens in polycystic ovary syndrome. So if you have polycystic ovary syndrome and obesity here, they both combine and cause insulin resistance. And insulin resistance refers to insulin here, which helps, it's like a key, if you like, that opens the door to the cell to allow glucose or sugar from the bloodstream in. So if you have insulin resistance, that door won't open so well, and your body trying to make that door open, makes more and more insulin. So you get this increased insulin, which then can affect the liver and the ovary and causes that increased androgen or testosterone that we were talking about before. So what else happens? So part of the, we don't really understand exactly why women get polycystic ovary syndrome, but certainly a family history of polycystic ovary syndrome it would make it more likely. There probably are genetic factors, but it's complex, and certainly lifestyle, so in terms of a lack of physical activity and poor diet and putting on weight, causes all of those changes that we were talking about before. And apart from causing things like hair growth and irregular periods, it also means that you can have problems with increases your risk of diabetes and probably heart disease. So that's really important that we need to be aware of polycystic ovary syndrome, screen women and try and help them prevent these things from happening. Importantly, the other thing that we need to remember is things around emotional well-being. Women with polycystic ovary syndrome have increased depression and anxiety when they have this. We don't know whether that's the same with Aboriginal and Torres Strait Islander women, but in other women with polycystic ovary syndrome, that's certainly an issue. So increased weight, as I said before, makes it more likely that a woman will have polycystic ovary syndrome. This graph here shows the Australian Longitudinal Women's Health Study, which shows that there was an increase over time with women if they become put on weight with a BMI greater than 30, how their risk increases. And a cross-sectional study, so a study that just looked at a large number of women, Aboriginal and Torres Strait Islander women in Darwin at one time, found that of those who had a normal or healthy BMI, that their risk was around 7 to 8%. Once their BMI went up to 25 to 30, it increased a little bit, and you can see that it increased quite dramatically, and nearly a third of them who had a BMI greater than 30 had polycystic ovary syndrome. So just to sort of try and help us put all of this information in context, we thought we'd have a hypothetical woman who's coming into a clinic who might be seeing you or one of the other health providers in your clinic. I certainly see women like Jess not infrequently. So she's 28 years old, she has irregular periods, she has put on weight in the last 2 to 3 years. She's been putting it on a little bit ever since she had her baby actually, but particularly more in the last 2 to 3 years, and especially around her tummy. Her weight now is 76 kilograms and she's my height. So that gives her a BMI of 28, which is in the overweight range. She's noticed that she has some facial hair, mostly on her lip. She has had a baby before, but that was when she was 20. After that she used Implanon for several years, and she had that removed 5 years ago and hasn't used contraception since then, and she's really starting to get a bit worried because she's quite keen to have a baby. And she does have a family history of type 2 diabetes. Just going to ask everyone here now, what problems do they think Jess has that might make you think that she has polycystic ovary syndrome?
Hair growth?
Mm-hmm, yep. That's definitely one of them. Sorry? Does anyone else have any other suggestions?
The trouble having a baby.
Yeah. So she has irregular periods, and that means that she's not releasing an egg every month. So that's making it hard for her to have a baby. And she's got the hair on her face, that's right. And what about Jess makes us think that she may have an increased risk of having polycystic ovary syndrome?
Her weight?
Yeah, so she's carrying some extra weight. And the family history of diabetes may suggest that she might be more inclined to have insulin resistance, possibly. So what do we do for Jess now? So initially we obviously have to do the tests that help us to know whether she has polycystic ovary syndrome or not. So we would do some blood tests which would measure those male hormones in her blood. We're pretty sure though already really, because of the irregular periods and the hair growth, we would be pretty sure that that's what she has. We would also need to look at her other health. So we would need to look at doing a diabetes check, checking her lipids, so her cholesterol, because we're concerned about her future healthy heart as well, her blood pressure for the same reason. We also need to check that she doesn't have any other reasons that might be stopping her having a baby, because a large number of women have, or couples have there's more than one reason why they're not able to have a baby. So we would be thinking, do we need to check whether she has blocked tubes that carry the eggs down from the ovaries into the baby bag? Has her partner fathered other children? We probably need to check him, and we'd need to make sure that she doesn't have any other things that might be causing irregular periods. So generally they're also things that we would check for in a blood test. And the other things that we also need to remember, of course, is that we need to make sure that she's had the other usual checks that will help her to have a safe pregnancy. So is she taking folate? Has she had her rubella checked to make sure that she's protected against that? And has she had a recent pap smear? So how do we and how does Jess manage her polycystic ovary syndrome? The most important treatment is lifestyle. And what we mean by that is what we eat and what we do. So a healthy lifestyle is going to be good both for her physical and mental health. And we always need to remember that even small changes can make a difference. So what happens in women with polycystic ovary syndrome if they lose a small amount of weight? Their periods can improve. They might get them every month. That will increase their chances of having a baby. It will decrease their future risk of getting diabetes, and it will decrease their risk of heart disease. So when it improves their periods, what I mean is that it often helps bring this balance of these messages between the brain and the ovary to come back to normal. So let's look at healthy eating first. The most important things to remember are that there are no special diets required. There have been studies looking at different diets in women with polycystic ovary syndrome, but none of them have been shown to necessarily be better than the other. It's more about reducing the amount that you eat, making healthy choices, and you can do this by just making small changes and setting small goals. We all talk about healthy eating, and it's easy to talk about. It is harder to do, but I think we need to make sure that women know that they don't have to necessarily make drastic changes, that even losing a small amount of weight can help. And it is really, you're not saying they can't eat anything that they like if they like chips or things, and you're not saying they can never have them. We're saying that you need to try and decrease the amount that you have. Try and make some more healthy food choices. And make, They may not be such small changes, giving up your soft drink for water, but it's definitely one that helps. And again, looking at physical activity, it has a range of benefits, not just for improving the symptoms of Polycystic Ovary syndrome, but it will also definitely help long-term health and will help emotional well-being. So when we look at Polycystic Ovary syndrome and physical activity, again, it's going to help the immediate symptoms and hopefully increase Jess's chances of having a baby, but it will also help her improve her long-term health. And again, I think the message that we need to give women is it doesn't mean that they have to be out there running or riding a bike or doing, you know, an excessive amount of exercise every day. It might just be about walking, and it's about building activity into your daily lives. So these are some things that maybe Jess could think about. Maybe she could ask some friends or family to go for a walk with her. Maybe she could walk her son to school, even a small amount, and increase it every day. Get her to set small goals. Some people find that things like pedometers, which measure how much you walk, because it often surprises you, you think you walk a lot more than you do, it can help. And you just need to remember that any and every little bit helps. And so just going back to all this, the most important thing to remember as well is that we're really only talking about small amounts of weight loss, so around 5%. So for Jess, that's around, you know, 4 or 5 kilos. So we're not talking about needing to lose a huge amount of weight to have quite significant benefits. So if Jess isn't pregnant after, so we've given her 3 to 6 months on, and she's been really good and she has lost the weight that we've suggested, she's been eating well, exercising, she's generally feeling a bit better in herself, but she still hasn't been able to have a baby. So some of the other treatments that we can do, we can use some tablets. For women with a BMI under 30, you can consider using metformin, which a lot of you would be familiar with. It's it's the most common tablet that you would use for diabetes. And that works by helping to improve that insulin resistance, so helping with that key that's stopping the glucose getting into the cell. And by doing that, it then helps to decrease the testosterone and to help all those cycles get back to normal. There are other tablets such as Clomid, which can be used alone or with metformin, and that works in a different way, but again is very effective in helping to get those eggs to grow and to be released, and so therefore to have a baby. And then if the other thing that you might end up considering doing is a laparoscopy, where you actually drill little holes into the ovary. And you might do that for a number of reasons. You might have concerns about whether her tubes might be blocked. And so if you were doing a laparoscopy to check for that, then that's a good time to also consider maybe drilling those holes in the ovary. And what that does is that it decreases the androgens or testosterone in the ovary, and again helps those periods and those hormonal cycles to settle back down to normal. And lastly, if none of those work, then the sort of last step in a way is looking at injections that will help the eggs to grow and be released, and that's often done with IVF, and that's obviously a fairly significant step. So what else could be worrying Jess? The other things that we talked about, so the hair growth, her irregular periods, her fertility, which we've talked about. You know, she's a bit worried about her future health, and not surprisingly, she's feeling a bit sad and overwhelmed by all of this. So the treatment of the hair growth, well, we can't really look at doing that now. The best treatment is actually laser for hair removal. But that's obviously quite expensive and not available for everybody. Lifestyle changes and losing weight may help. Using the metformin might help a bit. You can also use things such as the oral contraceptive pill, which is not useful for Jess at the moment. There are other medications that you can use, but you have to use contraception when you're using those, because if you become pregnant they can cause problems. And the effects of all of those things usually take quite a while to take effect because of the long cycle of hair growth. Managing her future health is, so we're talking about preventing her getting, or trying to delay the onset even of her getting diabetes and cardiovascular disease. So all those things we talked about before with lifestyle and exercise is just so important across the whole range of those issues, and trying to prevent her gaining weight is going to be the most important thing. So once women with polycystic ovary syndrome are carrying a lot of excess weight, it's really very hard for them to lose it. So trying to help them prevent putting it on in the first place is really important. Screening and prevention is going to be also very important for Jess. So we would do a diabetes screen, as we discussed before, and then we'll be doing that in Jess probably every year, so every 12 months. And she would also need her blood pressure checked and her usual women's health check at that time. And again, really trying to even have small amounts of weight loss is not only going to help her fertility, as we talked about before, but also reduce her risk of getting diabetes quite significantly. Women with polycystic ovary syndrome experience quite a significant amount of depression and anxiety. As I said before, we don't really know how that affects Aboriginal and Torres Strait Islander women, but it does highlight that we need to be concerned that we can help women be well emotionally as well as physically. So they're the things that we talked about before, and contraception can still be an important thing to think about in women with polycystic ovary syndrome. They may not release an egg or ovulate all the time, but they certainly can sometimes still, and so we do need to be aware of that and make them aware of that. So managing polycystic ovary syndrome really requires, because of the immediate problems with their that they can experience with hair growth, their irregular periods, wanting to have a baby, their emotional well-being and their future risk of diabetes and cardiovascular disease, really requires a team. It's not something that one health professional can provide. We're very fortunate at our clinic that we can provide that team with a doctor, a nurse, a dietitian and a psychologist, and it's always important to really think about how you can help these women, in that same sort of holistic manner in your clinic. It's not always easy, but it's something to have a think about. So I think my main, there's some good fact sheets and information on our website, which is written up there, and we'll leave some of those fact sheets for you to have a look at afterwards. And there are newsletters that also come out from Jean Hales that you can subscribe to. I think the main message that I think I'd like you to take away today is to be aware of the number of different ways that women with polycystic ovary syndrome can present. Encourage women to seek help, because a lot of the issues associated with it can be helped, or you can help prevent future problems that are associated with it. So it's important to encourage women to seek help. And I think the other issue that it's really important to be aware of is that by managing weight and having a healthy lifestyle, that you can not only fix some of these problems, but you can actually prevent some of them from happening in the future. So it's not all doom and gloom. There are lots of things that we can all do. So thank you very much for your time today.